Mr. Johnson, I had a chance to look at your films. I've seen the mass on your kidney. What have you been told so far?
Well, I've written some things down, and will I be in a lot of pain after this surgery?
Well, okay. Before we talk about surgery, let me ask you a few questions and explain what we're dealing with. Let me skip right to the end and tell you that I do believe you're going to need surgery. Okay? That's really the bad news here. But the good news is that there is a growth on your kidney, and I think we're going to be able to fully treat it, okay? So I don't think you're going to die from this, but let's back up a little bit. I do believe we are going to ultimately want to do surgery for what we found, okay? Right. But, you got this CAT scan of your abdomen. Were you having a lot of pain? Is that why the doctor ordered the CAT scan?
Yeah, and the pain was, it was a little mysterious, but then it was chronic, and I felt that it was time to go and see what it was all about.
Well, I do believe that your pain may not be related to this mass, and it was something you had that prompted this, and we're fortunate to have found the tumor, but the tumor may not have been the actual cause of the pain. Okay? But let me draw you a picture of what I think we're dealing with. So the tumor is on your left kidney. So the left kidney looks like this. There's a growth. It's solid on CAT scan. It has a blood supply, and it's about 5 centimeters in size.
Okay. So it's protruding like that.
Yeah, it comes out of your kidney like this. The bladder, of course, is here.
Right.
Now, based on the way this tumor looks on the CAT scan, I would estimate there's an 80% chance that this is a cancer. Okay.
So it could be malignant, or it's 80%.
Yeah, a cancer is something that is malignant, that has the potential to shorten your life. Now, as long as the tumor has not spread to other parts of your body, it's still treatable and technically curable. And so we have images of your chest, and we have images of your abdomen and pelvis, and there is no sign of spread. So we would be doing surgery with the goal of completely curing you and treating you. Okay? Now, if you have a growth in other parts of your body, like the colon or the breast, usually the first thing you do is a biopsy, which involves putting a needle into the tissue, taking out a little sample of the tissue, and having the pathologist look at it under a microscope.
So it's not that invasive?
Yeah, it's a simple outpatient procedure. But with the renal mass, we don't do biopsies in many cases. And the reason is that the biopsy may miss the tumor, although that's not common these days. But even if it hits the tumor, there are often areas of the tumor that contain only normal tissue, or what we call necrotic or dead tissue, and the pathologists aren't able to make a diagnosis. So if the pathologist says, hey, we found cancer in the biopsy, we would treat this. If the pathologist says, we don't see any cancerous cells, there's still about a 10% chance that cancer is there, but was just not detected on the biopsy. So that's called a false negative. So a biopsy has about a 10% false negative rate. And if I were to tell you, hey, the biopsy is negative, but there's about a 10% chance you still have cancer, most Americans who are healthy are going to still want the tumor treated.
So there's a bit of deception in this, and the way that we rid ourselves of the deception is through the tests and biopsy and this. On this mass, obviously.
That's right. So the biopsy isn't changing what we do. We're going to treat for a positive biopsy. We're going to treat for a negative biopsy. And if that's the case, then why do the biopsy, right? So there are certain circumstances where I would recommend a biopsy. But in your case, given that I know you're a healthy, active individual, I don't think a biopsy is going to be necessary.
Oh, that's good. Wow.
So let's talk about our options. I'm going to write them down for you here so you have them in writing. whenever you see a mass, you can always observe it without treating it for a while.
Right.
Now, you can get a sense for how fast it's growing and how it's behaving over time by observing it and getting another imaging study maybe in 6 months. If it's unchanged at that time, we might wait a year for the next one.
Okay.
And so observing it for a period of time is reasonable.
Right.
However, the bigger the mass gets, the higher the risk that it's cancer,
Right.
and higher the risk that it might spread and become incurable. So given your age, given your overall health status, which is good, and given the size of this mass, I don't think observation is the best option, but it is still a option, so I'm listing it here for you. Another option is to simply remove your whole kidney. So we could take the whole kidney out. That's called a radical nephrectomy.
So I've got half of a renal system happening if that happens.
You know, that's exactly right. Now, if you have one healthy kidney on the other side, you can live a normal life with normal kidney function. Keep in mind that there are a lot of people who donate one of their kidneys to friends and family members who are on dialysis, right?
Exactly.
So we know with one healthy kidney you can live a normal life. And from what we know from your blood test and your x-ray, your right kidney, the other kidney, is perfectly healthy.
Okay, that's good.
But I don't think we need to remove your whole kidney in this case. Another option is called a partial nephrectomy, where we simply take out the mass and a little margin of normal kidney, which ensures that the whole tumor is out. So that's called a partial nephrectomy. And that's actually the procedure, I think, that makes the most sense for you.
Is there a regeneration, excuse me, doctor, after that? So there's just...
That's right.
Yeah.
After your first year of life, after you're born, the kidney doesn't really grow. And so if we take part of it, it doesn't necessarily regenerate. But you're going to have 80% of your kidney on this side even after the surgery.
So the 80% renal function is fine for that side.
Absolutely.
Great.
Another option is referred to as ablation. So here we
electric charges.
So what we actually do is put a needle into the mass through your skin, and we can use intense heat or intense cold to destroy the tissue without actually removing it. So heating is referred to as radiofrequency ablation often, and cold is often referred to as cryoablation. And these are the least invasive of the treatment options, because you don't even have to go to the operating room. It can be done in the radiology suite, and the needles are placed right through the skin under local anesthesia, and it can be an outpatient procedure. However, these options are best when the tumor is less than 3 centimeters in size. And so ablation isn't the best for a tumor that's 5 centimeters.
Obviously size is critical, I guess.
Size is critical. The other thing is the ablation does have a higher recurrence rate. So the cancer is more likely to be still present after the treatment. And they also require more intensive follow-up with CT scans or MRIs afterwards. So for a younger, healthier patient with a larger mass like this, I think the best option is a partial nephrectomy. Let me tell you a little bit about the operation. We would do the surgery laparoscopically, so I'm going to draw a little figure here.
It's with a scope?
Absolutely. So this is your rib cage, your legs are here, your belly button is here. In the olden days, we used to always do this through a big incision. We referred to this as the open procedure. Nowadays, we do it through little keyhole-sized openings. And this is called laparoscopic surgery or robotic surgery.
I had it on both my knees.
So yes, so if you had laparoscopic knee surgery, it's similar to the way we do this operation. We put a camera inside. we use long instruments with little graspers.
I was able to
end.
watch the meniscus being taken out of my knee with that.
So here you're going to be asleep.
Right.
But
I'd want to be asleep on this.
Yes. So whether we do this laparoscopically or robotically, the size of the incisions will be about the same. The difference is with laparoscopy, the surgeon holds the instruments. With robotic surgery, the robot holds the instruments.
Right.
And you use little joysticks to control the robot.
Right. Okay.
Now, as far as you're concerned, the recovery time is going to be about the same.
Okay.
And you should just use whatever technology the surgeon wants to use because the outcomes and the recovery is going to be about the same.
Okay.
In your particular case, although I could do it either way, I would probably just use a laparoscope and not, I wouldn't need a robot.
How long would that surgery take, doctor?
Yeah, so the operation takes about 3 hours.
Okay.
This is a good time for me to describe some of the logistics involved.
Okay.
So you come for the operation, you stay overnight, and then the recovery time is going to be about a month. So most patients who are working will take a month off if they can. Patients who maybe work for themselves and need to get back to work a little sooner will often be working in 2 weeks. You know, you might need narcotic-based pain medicines for 2 or 3 days. And then for about a month after surgery, I ask you not to lift anything more than about 30 pounds. So just think about the amount of exertion it takes to lift 30 pounds and then keep all your activities to within that exertion for 1 month. And you asked earlier about pain. What we're going to aim for after surgery is that when you're not moving, for example, you're lying still or sitting still, you should feel no pain. Okay. When you cough, when you move, when you try to get out of bed, you're going to be sore. So that's the normal post-operative pain control we shoot for. Now the pills that you're going to take about 30 minutes to kick in. So you're just going to need to anticipate the pain and take the pills before the pain gets going. And by doing that, you can keep the pain away. And so just anticipate that when you move, you're going to be sore, but when you're not moving, you'll be totally comfortable. So you should be able to sleep without pain. Okay. So what I'm proposing is that we perform a laparoscopic partial nephrectomy. That would be the full name of the procedure we're talking about. There are some risks you should be aware of with this type of operation. I'm just going to list them for you as well. So anytime you undergo surgery, there's a risk of bleeding and infection. Okay. Now, think of the kidney as a big blood vessel. It filters blood and it makes urine. So when you cut into it, a couple of things can happen. You can have bleeding, and that risk is about 4%, where the bleeding requires a blood transfusion. Now, if you need a blood transfusion and you get a unit or two of blood, the bleeding stops on its own. But in about half of these cases, the bleeding will persist, and we may need to do another invasive or surgical procedure.
Is there blood in the urine as well?
To deal with the bleeding. Now the bleeding can be internal or it can end up in the urine. But we look out for both types of bleeding after surgery. The risk of infection is small, it's 1%. You can also leak urine. So the urine normally goes down this way, but if after the repair the urine leaks out of your tumor bed, then we may need to do a procedure to deal with that.
That would be internal, obviously.
That's right. That's called a urine leak. And in our hands, that happens in less than 1% of cases. Also, when we cut out the tumor, if we don't cut around the tumor but into the tumor, you can leave some of it behind. And then the tumor is right at the edge or margin of what we removed. So we refer to that as a positive margin, and in our hands that happens in about 2% of cases. and it may necessitate another operation.
Right.
Okay. There is always a risk whenever you do an operation of injury to other
peripheral
organs. Organs that surround the kidney, which may require more surgery.
Okay. That's understandable.
Yeah, fortunately that happens in less than 1% of
that's
cases.
Good.
Okay. And finally, I want you to understand that there is a risk of something called conversion. Now, what that means is we start out planning to do a partial nephrectomy, but for some reason, because of complex anatomy or scar tissue, we end up having to do a radical nephrectomy.
Oh boy.
So we convert to a radical. We start out planning to do a laparoscopic surgery, but we convert to an open procedure. So that can also happen. Conversions to either a radical or to an open occur in 1% of cases, so it's rare. But if we were to convert to a open procedure, your hospital stay and recovery will be longer. So for a laparoscopic surgery, you might be in the hospital 1 day. If you have to have an open operation, you might be in the hospital 4 or 5 days, and the recovery time at home will also be longer. At this point, I believe that if we take this mass out and it turns out to be cancer, you're not going to need any more treatment. But if the tumor happens to be growing into the fat around the kidney, it's going to be a slightly higher stage. The tumor might be a aggressive cancer, which is something you can tell by looking at it under a microscope. And if it is a more aggressive cancer than we anticipate, there is another therapy called sunitinib that you might benefit from. It's not a traditional chemotherapy. It's something we call an anti-angiogenic therapy because it helps prevent blood vessel formation. Anytime cancer grows, it needs to form new blood vessels, and if you prevent that, then the cancer can't grow.
Starve it off.
That's right. So the idea is that if the cancer is aggressive, it may have already spread to other parts of your body. And there may be microscopic amounts of cells in your lung or other parts of your body. And this therapy reduces the risk of that cancer growing. In other words, your cancer recurring. But I don't want to scare you too much by considering all those possibilities, but I do want you to be aware that after the tumor is removed, we may get more information from the pathologist that will examine it, and then you may benefit from this additional therapy. So I just want you to be aware that that is a possibility.
Well, this is certainly very thorough and informative, and it sets up a great strategy, Doctor.
Now, do you have any other questions I can answer for you today?
No, I think you've answered them all, and certainly the ones that I was really concerned about. You've alluded to all of them, and you've answered them as well as illustrate them. So this is really helpful.
Good well, Mr. Johnson, let's stay in touch.
I will.
And it's a pleasure meeting you.
Thank you so much.
Okay.